Okay, I am back. Let us continue. Everybody hearing me okay?
Yes, sir.
All right, good. So we're looking at the PHEMS diamond. So this was created to help you remember what is different about older patients. It's not intended to take the place of the ABCs assessment. Every patient gets ABCs and you will manage the life threats found in the ABCs. It's an acronym for you to consider, specific things when assessing a geriatric patient. So G, they are a geriatric patient, and I've said this many times. Older patients may present atypically. Be familiar with the normal changes of aging. E represents environmental assessment. So the environment can give you a lot of clues as to what is happening to the patient and what is the nature of the incident or emergency. Medical assessment. So the M represents medical assessment. Older patients tend to have a variety of medical problems and numerous medication. So you have to cipher through that information to determine what is really causing the problem today. Obtain a thorough medical history. And the S represents social assessment. Older people may have less of a social network. They may need assistance with activities of daily living. Consider obtaining information pamphlets about some of the agencies for older people in your area, right? And I am not a fan of old age homes. I am not a fan. So when I get older, I want to stay right here, right here, right? Some of the worst patients I have encountered in the field, both in Jamaica and overseas, is old age home. I have seen patients in terrible conditions, right? Terrible, terrible conditions. And I have experienced it myself here in Jamaica when my father-in-law got a stroke, right? So he got a stroke and we took him to, I think it was Cornwall Regional, and he was doing okay. And we decided that he was ready to be discharged. We took him out and we brought him into Kingston and took him to a old age home or nursing care home. And I mean, within the 2 weeks, we started to see decline in how he was interacting. And then they said to us, he's not eating very well. And then a couple days after that, I got a call from the practical nurse, and the practical nurse was telling me that he's not responding. So I said, what do you mean he's not responding? He's not responding, and she don't think he's alive. So I said, what? So I said to her, did you attempt CPR? And I am not kidding about this response. The practical nurse said to me, what name, so? That was her response, right? So I said, how long has he been like this? Over 2 hours. Over 2 hours, right? And that was the end. That was the end, right? He had passed on at that point. I want to age in my own home. I don't want to go to any old age home, any nursing home when I get older. I have no faith in those places. All right, now special considerations in assessing a geriatric medical patient. Assessing an older person can be challenging because of communication issues, hearing and vision deficits, alterations in consciousness, complicated medical histories, effects of medication. All right, now let's go into our patient assessment. So size up your scene, or perform your scene size up. Geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facilities, right? Many older people live alone. And you can't kill them for that, because I mean, hey, they feel safer in that environment, right? Much safer. Access may be hampered if their condition prevents them from getting to the door. Take note of negative or unsafe conditions. But the mechanism of injury or nature of illness may be difficult to determine in older people with altered mental status or dementia. Just remember that if you're not able to determine what is happening with the patient, look at the pupil reaction, look at the blood sugar, look at the pulse ox reading, right? Of course, you have to ask the family members and caregivers or bystanders why he or she called. And as I said, with these nursing homes or healthcare, old age healthcare facilities, they never know anything about the patient yet. They never can tell you anything, right? Not sure, you would have to I ask the nurse on the previous shift or the nurse on the other shift. They never have no information to give you regarding the patient. Multiple and chronic disease processes may also complicate the determination of the NOI. Chest pain, shortness of breath, and altered level of consciousness should always be considered serious, right? So chest pain, difficulty breathing, and altered mental status or altered level of consciousness should be considered serious, right? So the general criteria still apply for your scene size. So make sure your scene is safe, take standard precautions for yourself, your partner, right? Determine the NOI or MOI, how many patients you have, the need for additional resources, and if the MOI is considered significant, then you have to consider spinal motion restriction, and a vacuum mattress is preferred. If not, then a spine board with padding. For the primary assessment, this is where we will identify any immediate and potential life threats and address them, right? So address life threats, determine the transport priority, form a general impression. You should be able to tell if the patient is generally in stable or unstable condition. Use the AVPU scale to determine the patient's level of consciousness. Airway and breathing, right? So after the LOC, how is the patient's upper airway? How is the lower airway? Anatomic changes that occur as a person ages predispose geriatric patients to airway problems. Ensure that the patient's airway is open, not obstructed by dentures, vomitous fluid, or blood. Anatomic changes affect the person's ability to breathe effectively, right? So it can affect their ability to move their chest, right? And you have to be looking for that. So, and you by now, everybody should know what to look for to determine if they need to bag a patient or breathe for a patient with a BVM. That is my expectation at this stage. Loss of mechanisms that protect the upper airway cause a decreased ability to clear secretions. Pay attention to that airway, right? And suction as needed. Airway and breathing issues should be treated with oxygen as soon as possible. So once there's a airway issue, if it's upper airway, it's position, keep clear, maintain, right? Lower airway management will always be oxygen. You have to determine if it's going to be supplemental, high or low flow, or positive pressure with high flow. That will be guided by your assessment and what the assessment findings are showing. Circulation, poor perfusion is a serious issue. In the older adult, physiologic changes may negatively affect circulation. Vascular changes and circulatory compromise might make it difficult to feel a pulse. All right, now after your ABCs assessment and you have addressed all your immediate and potential life threats, the next step is transport decision. So at this stage, what is the patient's GCS? You should have an idea at this point. Is it a load and go patient? Is it a stay and play patient? Does this patient require a rapid scan or a focus? These are questions you should be able to answer at this point. So transport decision. Any complaints that compromise the ABCs should result in prompt transport. Determine conditions that are life-threatening. Treat them to the best of your ability. Provide transport to priority patients. All right, now priority patients are those who have poor general impression, airway or breathing problems, acute altered level of consciousness, shock, severe pain, uncontrolled bleeding. Older people will decompensate very quickly or easily, right? Now, after the primary assessment phase, next comes the history taking. So you're going to investigate the chief complaint, find and account for all medications. Find and account for all medications. Do not write a bag of medications on your run sheet. Obtain a thorough patient history. Determine early whether the altered LOC is acute or chronic, if possible. Multiple disease processes and multiple and or vague complaints can make assessment complicated. Collect a sample history. You may have to rely on relative or caregiver to help you. List the patient's medications or take the medications with you to the hospital. The last meal is particularly important in patients with diabetes. Transport to a facility that knows the patient's medical history if possible. After the history taking phase, we have the secondary assessment phase. Maybe perform on-scene en route to the emergency department or not at all. Physical examinations. An older patient may not be comfortable with being exposed. Protect his or her modesty. Consider the need to keep your patient warm during exam. For your vitals, the heart rate should be in the normal adult range, but may be compromised by medications such as beta blockers, which is a blood pressure medication. Right? Weak or irregular pulses are common. Circulatory compromise may make it difficult to feel a radial pulse. Consider other pulse point. Don't freak out, just check another area, right? Blood pressure tends to be higher, so as we age, if we're not physically active, eating properly and exercising and all of that good stuff, the systolic tends to rise. So the blood pressure tends to go up as we get older. Capillary refill is not a good assessment because there is poor vessel function. in the peripheral areas. So it might not be a reliable tool for your geriatric population, right? It is more reliable in the pediatric population. The respiratory rate should be in the same ranges or the same range as in your younger adult. Be sure to auscultate breath sounds, careful pulse oximetry, carefully assess pulse oximetry data, right? So don't treat the pulse ox, treat the patient. After your secondary assessment phase, then we have the reassessment. Reassess the geriatric patient often. Reassess vital signs, reassess patient's chief complaint, recheck interventions, identify and treat changes in the patient condition. You will consider your interventions, maintain a position of comfort, assist ventilation as needed, administer glucose for a patient with diabetes if there is no contraindication. In specific cases, you may also assist with nitroglycerin, aspirin, or inhalers. Provide psychological support. At this phase, you're going to do your documentation using the desired format based on your organization. So you will either use the chart method, the SOAP method, or chronological order, right? And you always want to think about what is it that the patient is complaining of, what did you observe, what was done based on your observation, how did the patient respond to that, and what was your method of transportation? Was it high priority transport, low priority transport, right? All right, now trauma and geriatric patients. Conditions that create risk and complicate assessment. Slower homeostatic compensatory mechanism, right? Limited physiologic reserves. Normal effects of aging on the body, existing medical issues. Physical findings in an older adult may be more subtle and more easily missed. Mechanisms are much more minimal. Recuperation from trauma is longer and often less successful. Many injuries are under triage and under treated. Because of changes in the body, older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. They commonly suffer injuries to the legs and arms. Other injuries can be caused by secondary collision onto the street, often involving the head, right? And remember, the geriatric population, the brain shrinks, so there is more space inside of the skull, which put them at a high risk for blood vessels tearing, resulting in bleeding inside of the skull. Older people are more likely to experience burns because of altered mental status, inattention, and compromised neurologic status. Risk of mortality is increased when there is underlying medical condition, there is a decline in the immune system, fluid replacement is complicated by issues with their kidneys. Higher mortality from penetrating trauma in older adults, especially gunshot wounds. Penetrating trauma can easily cause serious internal bleeding. Falls are the leading cause. Falls are the leading cause of fatal and non-fatal injuries in older adults. Nearly half of the fatal falls in geriatric patients result in traumatic brain injury, and I have already stated why more than 2 times. So third time is the brain decreases in size. So the brain goes through atrophy as we get older, right? It shrinks. Because of that, there is more space inside of the skull. So more shifting can occur. If more shifting can occur, more tearing can occur. So when they fall, blood vessels are easily torn, resulting in bleeding on the brain, and that can lead to a traumatic brain injury. All right, now anatomic changes and trauma. Changes in pulmonary, cardiovascular, neurologic, and musculoskeletal systems make older patients more susceptible to trauma. A geriatric patient's overall physical condition may lessens the body's ability to compensate for simple injuries. As a result of osteoporosis, older patients are prone to fractures, especially the hip. Hip fractures is very common in your geriatric population, right? Contributing factors, stresses of ordinary activity, a standing fall, vitamin D and calcium deficiencies, metabolic bone disease, tumors. Geriatric patients with osteoporosis are also at risk for pelvic fracture, and this is a life-threatening fracture. So a pelvic fracture is a life-threatening fracture. With age, the spine stiffens as a result of shrinkage of the disc space, and vertebrae become brittle. Compression fractures of the spine can occur as a result of that. Now, because the brain tissue shrinks with age, older patients are more likely to sustain closed head injury. Acute subdural hematoma are among the deadliest of all head injuries. Serious head injuries are often missed because the mechanisms may seem relatively minor. Other factors that predispose an older patient to serious head injury would include long-term abuse of alcohol, recurrent falls, and repeated head injury, anticoagulant medications. All right, now environmental injuries. Internal temperature regulation is slowed. Half of all deaths from hypothermia occur in older people, including most indoor hypothermia deaths. Death rates for hyperthermia are more than doubled in older people. People older than 85 years are at the highest risk. All right, now special considerations in assessing traumatic patients. Trauma is never isolated to a single issue when you are assessing or caring for a geriatric patient. Very important point. So trauma is never isolated to a single issue. You have to be thinking about other things. You have to be looking out for other clues that could indicate other issues. All right, so you see size up. Look for clues that indicate your patient's traumatic incident may have been preceded by a medical problem. Bystander information may be considered. The MOI is important in establishing whether an injury is considered critical and it affects treatment and transport consideration. In your primary assessment, we manage life threats straightforward. We know that at this point. Determine transport priority. Recommended that older trauma patients be transported to a trauma center. Out here, the most appropriate healthcare facility that can handle the nature of the call. Form a general impression: is the patient's condition stable or unstable? Use AVPU, use a Glasgow Coma scale, determine mental status. Right? Airway and breathing. If the patient is talking to you, airway is open. We know this by now. Patients who have noisy respirations have airway compromise. Older patients may have a diminished ability to cough, so suctioning is important. And remember, once you hear noisy breathing, it means that your patient will require more than oxygen, right, to fix that. Assess for the presence of dentures. For circulation, manage any external bleeding immediately. Drinking alcohol and taking anticoagulant medications make internal bleeding worse or external bleeding more difficult to control. Older patients can more easily go into shock. Patients who were hypertensive prior to injury may have a normal BP when they are actually in shock. Very important. Patients who were hypertensive prior to injury may have a normal BP actually in shock. And this is the reason why I've always emphasized we do not treat numbers. We treat the patient presentation. That's what we will treat. Patient presentation. All right, now in your history taking, investigate the chief complaint. Considerations in your assessment must include past medical conditions if they are not currently acute or symptomatic. Secondary assessment, physical examination. Perform in the same manner as for an adult, but with consideration of the higher likelihood of damage from trauma. Any head injury can be life-threatening. Check lungs, look for bruising and other trauma and other evidence of trauma. For your vital signs, assess pulse, blood pressure, and skin signs. Capillary refill is not reliable in this age group. Remember that some older people take beta blockers, which will inhibit their heart from becoming tachycardic. So you might see bradycardic rhythms or bradycardia in these patients. And not only that, to the fact that it is a beta blocker, it can also interfere with how the body uses the insulin, right? And it can interfere with how the glucose reaches the cell. All right, now reassessment. Repeat the primary assessment. A geriatric patient has a higher likelihood of decompensating after trauma. Interventions, broken bones are common and should be splinted. All right, now interventions. Do not force a patient with a joint flexion or kyphosis into a normal position. And kyphosis is when they have that abnormal curve in the back, right? Provide blankets and heat to prevent hypothermia. Communication, documentation. Communication can be challenging. Provide psychological support as well as medical treatment. All right, now assessment of falls. Falls can be caused by medical conditions such as fainting, that are one of the most common ones, a cardiac rhythm disturbance, or a medication interaction. Whenever you assess a geriatric patient who has fallen, it is important to find out why they fell, right? So why they fell, what happened prior to the patient falling, right? Consider that the fall may have been caused by a medical condition, possibly life-threatening. Response to nursing and skilled care facilities. I hate nursing care facilities. Anyway, many calls will occur at a nursing home or other skilled care facilities. Used to get a lot when I was working on the unit in Jamaica. Most of the calls were from nursing care facilities or nursing homes, right? Calls can be challenging. Very challenging. Patients often have an altered level of consciousness. Staff may be spread thin and may not know how to assist you. And of course, some of these staff don't have proper training. Ask what is wrong with the patient that is new or different today. They may or may not be able to give you that information, and I would say less than 50% were able to give me valuable information about the patient, right? Because there is just a knowledge deficit. And I mean, it's to bring in practical nurses in the nursing care facility, because I think how it works in Jamaica is most of these facilities will have practical nurses that take care of the patients on a day-to-day basis, and then a RN comes in occasionally, or the RN comes in if something is wrong, right? But there is no set standard for practical nursing training in Jamaica. So the level of training fluctuates significantly, and you don't know what is the skill level of these persons, right? And the patient suffers as a result. Patients really suffer, right? I can recall a particular call I had in the past where when I got into the room where the patient was in his urine. So I'm on the bed and you can smell the ammonia, right? Can smell it. Worst calls I've had, nursing care facilities. Anyway, let me not go off on a tangent. Now, infection control needs to be a high priority for EMTs, especially when you're going into these places. Make sure you mask up, right? Make sure you mask up. MRSA, methicillin-resistant Staphylococcus aureus, or MRSA infections are very common and spread quite easily within these environments. Many infections in the hospitals are caused by vancomycin-resistant enterococci, right? Just means that the bacteria is resistant to vancomycin. The respiratory syncytial virus causes an infection of the upper and lower respiratory tract. These are things we need to keep in mind. Clostridium difficile is a bacterium responsible for most common cause of hospital-acquired infectious diarrhea, right? Typical alcohol-based hand sanitizers do not inactivate or kill CD. All right, now dying patients. Yes, Miss Nesbitt.
Sure, and I guess if you're transporting a person with C. difficile, sir, when you're decontaminating the ambulance, you'd have to use bleach, right, sir, instead of any alcohol-based thing. So that's important, right?
Yes, that would be correct. That would be correct. Definitely. All right, now dying patients. More patients are choosing to die at home rather than in a hospital, right? And we know why. We know why. Dying patients receive palliative care, be understanding, sensitive, and compassionate. Determine if the family wishes for the patient to go to the hospital or stay in the home. Advance directives, specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to the patient who cannot speak for themselves. Dealing with advance directives has become more common for EMS providers. All right, now advance directives may take the form of a do not resuscitate order. Gives you permission not to attempt resuscitation for a patient in cardiac arrest. DNR does not mean do not treat. basic ABCs should still be provided. When transporting patients from nursing facilities, consider these guidelines. Patients have the right to refuse treatment. A DNR order is valid only if it is in the form of a written order by a physician. Review state and local protocols. When in doubt, try to resuscitate the patient. All right, now elder abuse and neglect. Any action on the part of an older person's family member, caregiver, or other person that takes advantage of older person, property, and emotional state. Includes action of commission and acts of omission. The extent of elder abuse is not known for several reasons. It has been largely hidden from society. Yep. Definitions of abuse and neglect among the geriatric population vary. Victims are often hesitant to report the problem. The abused persons may feel traumatized by the situation or be afraid that the abuser will punish him or her for reporting the abuse. Elder abuse occurs more often in women older than 75 years. Abusers of older people are sometimes products of child abuse themselves. Take note, so pay close attention to the environment that the patient lives in, right? Soft tissue injuries that cannot be explained by the person's lifestyle and physical condition. Look out for that. Suspect abuse when answers are concealed or avoided. Suspect abuse when you are given unbelievable responses. All right, now information that may be important in assessing abuse includes caregiver apathy about the patient's condition. They don't seem very concerned, right? They get very defensive. They are not giving the patient a chance to respond to your questioning. Repeated visits to the ED or clinic, a history of being accident prone, unbelievable or vague explanations of injuries. Psychosomatic complaints, chronic pain without medical explanation, right? Self-destructive behavior. They start to have problems with eating and sleeping. Depression or lack of energy, substance or sexual abuse history. Repeated abuse can lead to a high risk of death. And there's a nice little table that categorizes elder abuse as physical, psychological, and financial. Make a note of that little table. All right, now signs of physical abuse. Inflicted bruises are usually found on the buttocks and the lower back, genitals, inner thighs, face, and ears. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites are typically inflicted on the upper extremities and can cause lacerations and infections. Typical abuse from burns is caused by contact with cigarette, matches, heated metal, forced immersion into hot liquids, chemicals, electrical power sources. Check for signs of neglect such as poor hygiene, right? Poor temperature regulation, lack of reasonable amenities in the homes. Regarding injuries to the genital area or rectum with no reported trauma as evidence of sexual abuse in any patient. So regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Geriatric patients with altered mental status may never be able to report sexual abuse. Many women do not report cases of sexual abuse because of shame and the pressure to forget, right? And this slide will bring us to the end of geriatric emergencies. So what is important about this chapter? Knowing how the systems in the body will change as a result of aging, and knowing what are the complications that can arise from these changes. That's important. Knowing that most of the medical conditions that we encounter in the general population, we will encounter them as well in the geriatric population. However, there is a section of the geriatric population that will not have what we would classify as typical presentation, right? Being able to communicate effectively is going to be important. Consider your gems, right? Consider your gems. Geriatric, your environment, medical assessment, social assessment. That will be important to your geriatric population. It's the same patient assessment with a few considerations. And that's the end of geriatric emergencies. Now, it is also the end of, for me, in terms of doing live lecture presentations. So from this point on, I won't be doing any more live lectures, right? So there is another chapter that remains in this module, patients with special challenges. That's a chapter you will review on your own. The ambulance operations chapter, ambulance operations module, you will also be reviewing on your own as well. So I'll set up the module access for that. I'll leave links to YouTube lectures, review all the materials in the module, right? And use that to prepare for that section of the course, which is basically the final section of the course, right? But you'll be doing self-directed learning. So this is it for me where live lectures are concerned. Anything I'm doing beyond this point will focus on either ECG, basic ECG, cardiac monitoring, and skills, right? So from this point on, all I will be focusing on is your skills. Any questions? I'm having a connection problem. Can you hear me? I think the computer just freeze up.
Sir?
My computer is not responding. All right. So this is what I need to do. Let me close this. Go ahead.
Hello, good morning, sir.
Yes.
My question in relation to this whole geriatric thing. What if you have a geriatric and you're in the process of administering life-saving care to the patient in the back of the ambulance, and the patient tells you that his last wish is for you to just let him go. He doesn't want to continue living anymore.
That's
Like,
not a decision for you to make as a EMS responder.
okay, so
Right?
you would
So
still just
you have to do your job at that point. You can make that decision. You don't have the power to do that.
okay.
Right? All right. Any other question? Who's that now? Yes, Miss Nesbitt, go ahead.
Sir, the skill, sir, is that the same thing as BLS, the BLS chapter in the book, sir?
When I say skill, I mean everything. BLS, EMT skills, everything.
And
Yes.
it's the two chapters we're supposed to review is the ambulance operation and what again?
Ambulance operations is a module. So there's more than one chapter in that module.
Ambulance operations and what again, sir?
And patient with special challenges. You get that?
Yes, sir.
All right. So ambulance ops is a module. I think it has ambulance operation, vehicle extrication and special rescue, incident command, weapons of mass destruction, and team approach. You won't see any questions on team approach, but you can review it. You won't see any questions on weapons of mass destruction, right? So you'll definitely see questions on ambulance ops, vehicle extrication, and incident command system. I'm not going to be putting any weapons of mass destruction or team approach questions. All right, so let's, yes, Ms. Johnson.
Sorry, when is the medical emergency exam?
This week, sorry, next week, I should say. What was the date I gave you guys?
You
Nobody
didn't give us
wrote
a
that.
specific, sir, you said about the 25th, but it may not necessarily be on that day.
Right, so you're going to get that exam this week, so you should be well prepared for it now. Wouldn't you agree?
No,
This
sir.
week, why not? If you're not prepared, you're not putting in the work. But expect that exam to be up next week, right? Not necessarily the 25th, but certainly during the week, whether that's Wednesday or Thursday. But you'll be doing that exam next week, so be prepared for it. Any other questions? All right, so let's go back to our skill review that we're doing from the previous class, right? Let me see, 1, 2, 3, 4. All right, so we're still on Airway, so we're going to be doing Airway again today. Today it's Airway again. Let me get my clock ready. Miss Jackson. Miss Jackson. I'm not hearing you.
Bye.
Miss Jackson, present or absent? Something wrong with your mic? Yes or no? Type it quickly. Is there something wrong with your mic? Okay. All right, mute your mic, Miss Jackson. All right, Miss Johnson. Okay, Airway is the scale. 5 minutes required. Scenarios is as follows. You have a patient that's found at home, not responding, not showing any signs of breathing. There is no spinal injury. Walk me through the process of managing this patient's airway. Let me know when you're ready.
Okay, sir, I'm writing. So the
Go ahead.
patient, it was found at home, not
Yes.
responding, no sign of breathing, no
Mhm.
spinal injury.
No spinal injury. Go ahead.
Okay, sir, I'm ready.
Go ahead.
Is my scene safe?
Yes, it is.
NO, I'm suspecting an NOI, which is, patient unresponsive, not breathing. I
Mhm.
am going to be wearing the minimum protection, which is gloves. Is there more than one patient?
One patient.
I am thinking about calling ALS because I am not quite certain what is happening. Since the first person is not breathing, they need advanced life support.
Okay.
So I am going to, the person is where, sir? In the room, on the bed, on the floor?
Patient is on the bed.
In what position, sir?
Supine.
Okay. So I am going to check level. Well, the patient is unresponsive, but I am still going to check to see if the patient is responding to pain. If the person, oh, unresponsive, not breathing. Okay. So, sir, I'm going to um. So I'm going to open the airway of the person since the person is unresponsive,
That's what
and
dispatch told you. So dispatch gave you information about this patient. Don't make
okay.
assumptions.
So I'm still going to check the level of consciousness. So is a male or female, sir?
Male.
Hello, sir. Sir?
No response.
Okay. Trying painful stimuli.
Doesn't respond to pain.
So this person is unresponsive. So I am going to check, open the airway to see if there's anything at all in there that is causing the
Nothing
obstruction.
in the mouth. Nothing in the mouth.
So I'm going to do since the patient has no spinal injury, I'm going to do the jaw thrust, that one. The maneuver, sir, to open the airway. Is the
Okay.
patient breathing when the airway is open?
There's
Gasping
no
for air,
breathing.
anything like that?
No
No
breathing.
breathing. So I am going to use seriously? No breathing. Okay. So I'm going to use a BVM, sir, in order to help with breathing,
Okay, I'm listening.
and then I am thinking. So I'm going to use a BVM, or no? I mean, after I check that there is no breathing, I should check circulation to see if the person has a pulse. Does the person have a pulse, sir?
Yes, there is a pulse.
Okay, so this is when I'm going to use the BVM to assist with ventilation.
Okay,
So I'm going to do one breath every 5 to 6 seconds. Has the person, I mean, oh God. 6 minutes gone yet, sir?
I'm
So,
listening.
so I will help with the ventilation, sir. And then, I'm not working by myself, right?
No, you're not.
So I'll ask my partner to help with the ventilation using the BVM. And then I would do, sir, my brain is, anyway. Mm,
Finish?
yes, sir.
All right. So walk me through your thought process. Walk me through your thought process. What were you trying to do for this patient?
Since the person is not breathing, sir, I
Mm-hmm.
am trying to help with ventilation so that perfusion can continue. And since the person has a pulse, it is obvious that there is the, I mean, there is something going on with the heart. It's not like the heart stopped completely,
Mm-hmm.
but there is some form of circulation. But I need to make sure that it is helping it to continue adequately, so that the cells, especially the ones in the brain, don't die.
All right,
That's
I
what I
hear
like.
you.
That's what
I hear you. All right, so I'm not gonna say anything. I won't give you any feedback at this point. Miss Nesbitt, you're up. It's the same scenario. Patient found at home, doesn't seem to be responding, doesn't seem to be showing any signs of breathing. You're required to manage the patient's airway. Go ahead.
Ensuring scene safety, the scene safe,
Scene is safe, yes.
nature of illness, respiratory, doing standard precaution by using gloves, number of patients,
One patient.
alright, considering ALS, forming a
Okay.
general impression, patient is not breathing, assessing level of consciousness using ABPU, patient, hello, sir, are you hearing me? Are you hearing me, sir?
No response to voice.
Painful stimulus, squeezing the trapezius.
Doesn't respond to pain.
All right, assess the airways, now assessing the airways, positioning the head using the head tilt, chin lift maneuver. Is the airway patent? No?
Nothing in the mouth.
Okay. I'm assessing breathing and circulation simultaneously by palpating, looking at, feeling if there's any breath coming out of the patient's mouth, looking at respiration or breathing for rhythm, quality, rate. When I'm looking at the quality, I'm looking if the chest is rising or falling. Is it rising or falling adequately, sir?
No chest movement.
All right. I'm determining the rate using the cartridge. What is the rate? The
Patient has a
respiratory.
pulse rate of 48 beats per minute.
Okay. Because of that now, is it weak, fairly rapid, what?
Weak regular.
Alright, so sir, determining that I need to use an oropharyngeal adjunct in this patient, I'm measuring it using the lip, the end of the lip and the earlobe. I'm positioning the oropharyngeal adjunct in the well, not in the opposite position of function, and then I'm putting it in the mouth, rotating it to 180 degrees. I am now going from a back valve master. My partner has set up the apparatus already. Putting on the mask, and I'm squeezing at a rate of 1 breath every 5 to 6 seconds. Is the chest rising, sir? Am I seeing anything?
Patient start to gag.
Patient is gapping, then I will remove the back valve mask, turn the patient's body as a unit, remove the oropharyngeal adjunct, get my suctioning machinery up to 300 millimeter of mercury pressure. And is the secretion a lot or small?
Large amount of secretions.
Using a rigid catheter, attaching it and going into the mouth from suctioning from side to side, coming out in a circular motion. Sir, is the patient okay now? No more gagging?
Airway is clear.
All right, patient going to reassess everything now, sir. So I'm checking back the pulse. What is happening? Because there's obviously a change in the patient's level of consciousness. What's happening now with the pulse, sir?
Pulse is still below 60.
What about the breathing, sir?
There is no chest rise.
All right, so I'm now switching to a nasopharyngeal adjunct because of the gag reflex in the patient. Putting it in the position of function and measuring between the tip of the nose to the earlobe, and lubricating the nasopharyngeal adjunct, putting it in the right nostril with the bevel pointed towards the septum. I'm inserting it, sir, and I have on the back valve mask now, delivering 100% of oxygen.
Ventilations are poor.
The ventilations are poor.
Yep, you're not getting good ventilations.
All right, sir. I am going to see if I need to reposition. Since the patient, what I'm going to do now, I'm going to see if I need to simultaneously squeeze the bag for every with the first 5 to 10 breaths that the patient is taking, sir. I'm going to be squeezing it in accord with the patient's breath. Is that improving the situation? And then I will switch to 1 breath every 5 to 6 seconds. Is that improving the situation?
Ventilations still poor.
Wow, this patient is going to die on me. All right, so what I'm doing now is to ventilation is still poor. Have I exhausted my 5 minutes as yet?
Sorry?
Have I exhausted my 5 minutes?
No, not yet.
Ventilation is still poor. So I'm rechecking the patient's pulse. Is there a pulse, sir?
Yep, pulse still present.
I'm removing the nasopharyngeal adjunct. I am repositioning the patient's head to see if the airways. Is the airway still patent? I'm repositioning the patient.
Nothing in the mouth.
This patient is for eye level transport. ALS has just
All
come
right,
on
so
the
that's your 5 minutes. 5 minutes. All right, now I actually start the 5 minutes when you guys start to make contact with the patient. I don't start it at the scene size up. You really don't need a scene size up for this skill station, right? It actually starts with standard precautions and you make contact with the patient. But if you guys are reading your skill sheets, you would know that. But anyway, Mr. Jennings, go ahead. Same scenario.
Morning, how you doing? All right,
Yes.
so You said that there's no. I don't need to go through the scene size of it then.
Not necessary for this skill station.
All right. So I'm on scene. I'm taking standard precautions, gloves, mask, 'cause I'm not sure, what could take place. I'm approaching my patient. I'm checking his level of consciousness at this point to determine whether he's responsive or unresponsive, and I'm using the AVPU scale. Is my patient responding voice?
No response to voice.
No response to pain?
No response to pain.
At this point, I'm determining my patient to be unresponsive. I'm going to now open the airway, and I'm going to use look, listen, feel. So I'm checking the pulse simultaneously while assessing the breathing and looking to see if the airway is clear. Is the airway pain?
The airway is
As in,
clear. There is no
am I
chest
feeling any
rise.
breaths?
Hold on. Airway is clear. There is no chest rise. There is a pulse.
What is my patient's pulse?
What do you mean? What is your patient pulse? What is it that you want
Rate.
from
I want the rate of my patient's pulse. Is it fast, slow, or normal?
patient? Has a pulse rate of 48 beats per minute.
Okay, that's slow. I'm also asking for the rhythm and quality. Is it regular or irregular? And is it weak or strong?
It is regular, weak.
Regular. At this point, because my patient is apneic, I want to now start to breathe for my patient. So I'm going to use an oropharyngeal airway. I'm measuring from the corner of the lip to the jaw of the mandible. I'm inserting the OPA upside down and rotating it 180 degrees to scoop the tongue out of the airway. I'm now going to open the airway by doing a head tilt chin lift, placing on the bag valve mask, and I'm breathing at one breath every 5-6 seconds.
Okay.
I'm
Patient start to
breathing.
gab. Patient start to gab.
My patient starts to guide. I want to turn the patient's head to the side, and I want to remove the oropharyngeal airway. Am I noticing any vomitus or any secretions?
Yes, there's a large amount of secretions coming out of the patient's mouth.
Is it chunky or is it fluid? That's a good
All right.
question to ask.
Hold on a sec. All right. Continue, Jennings. What were you saying?
Oh, saying chunky, fluid.
Fluid.
I'm going to use a flexible catheter. I'm going to test the suction, setting up the suction. I'm going to set it at 300 millimeters of mercury. I'm then going to measure suction from the tip of the mouth to the same way I measured the OPA to the jaw of the mandible, placing my finger as a marker. I'm going to insert it and begin suctioning in a circular motion coming out of the airway until all of the fluid is removed. Is my airway
All right.
now?
You have cleared the airway.
All right, I'm starting from the top again, confirming that there was a change. I'm checking the patient's level of consciousness. Is my patient responding to verbal stimuli?
No.
Patient responding to pain?
Patient responds to pain.
Good. I'm going to insert, I'm now going to check the airway again. And now I'm going to check breathing using look and feel. Am I feeling any breaths now that the airway is clear? And am I noticing a change in pulse?
All right, the breathing is present.
The pulse.
Pulse is present. If I said breathing is present, pulse must be present.
True. Sorry about that. All right.
Right.
So now that my patient has started to breathe again, spontaneous breathing, I'm going
I
to
didn't say anything about
assess.
the breathing being adequate. Breathing is
No,
present.
I'm going into that now. I'm going into that now because
Okay.
it returned. So I'm going to now say I'm assessing the breathing for the rate, rhythm, quality, and depth. So
Okay.
what is my
Patient
patient's
is
rate of breathing?
breathing. Patient is breathing at Patient is breathing at 6 breaths per minute. Poor chest rise bilaterally.
Okay. So because the poor chest rise bilaterally and the low respiratory rate, I want to continue breathing for this patient. I want to get an appropriate size NPA measuring from the tip of the nostril to the earlobe, the front of the earlobe. I'm going to lubricate the NPA. I'm going to insert it into the right nostril with the bevel facing septum. I'm inserting the A, and I'm now
Okay.
going to position the head to open the airway. I'm going to attach the BVM to my patient's face. I want to synchronize with the patient's breathing for the first 10 breaths, and then I want to slowly increase the breathing until it's adequate, until
All
we're
right.
achieving about 20 breaths per
That's it. That's it.
minute. Okay.
All right. So, Miss Johnson, you present?
I am, sir.
All right. Do you know why things went downhill for you?
Yes, I do, sir.
Why?
Because I'm thinking too hard.
Okay, because you're thinking too hard. Why is it that you're thinking too hard?
Because I'm not practicing.
Okay. All right. So you know what you need to fix then. It sounds like.
Yes, sir.
Okay. All right. All right. So with you, Miss Johnson. So I had some questions that I wrote down. Why did you decide to do a jaw thrust maneuver?
A jaw thrust. Sir, that's not what the one I was going to use, sir. It's the other one.
That's
The
what you said.
chin lift. I know that was what I said, but
Okay.
that was not the one because the person has no spinal injury, so there was no need for me to use that one, sir.
Okay. Well, that's what I wrote down. That's what I heard. All right.
Okay.
Your pulse check was delayed. So you delayed your pulse check and there was no pulse assessment. So after I told you that there was a pulse, you didn't um, mention anything about a pulse assessment. What was the other thing? And this was for everybody. BVM without no O2. So if you're gonna use your BVM, oxygen needs to be attached and it needs to be at a high flow rate.
And oxygen, sir.
Who was that?
It's Lorraine Nesbitt, sir. I did say at a
I'm
point.
I'm talking up to I'm talking to Miss Johnson right now. Hold on, I soon come to you. I will get to you shortly. You got that, Miss Johnson?
Yes, sir.
So the things I wrote down. So for you, you're not following your sequence, right? I'm not seeing level of consciousness. I'm not seeing airway position. I'm not seeing a step-by-step approach. And that is the reason why you have to be thinking that hard. If you follow a step-by-step approach, it will be much easier for you to perform the assessment. So wrote down the jaw thrust maneuver, pulse check being delayed, no pulse assessment, BVM with no O2 attached. Did you consider that the patient was in a bed, Ms. Johnson?
Sir, I did ask you where the patient was, but I didn't
Yes, but
take it into consideration.
did you consider how the patient being in the bed would affect your management of the patient?
No, I never did, sir.
Okay, so that would be something you have to consider, right? So it's either you're gonna move this patient from the bed to your stretcher or on the ground, where you need a flat surface to work, and the bed might not be sufficient for that, right? Gonna need a flat surface to work. All right, so that's Miss Johnson. Nesbeth, you know, again, did you consider the fact that the patient was in the bed or in a bed, Miss Nesbeth?
No, I didn't.
All right, that's something to consider and how it will affect your management of the patient.
Why the patient went to
I'm not hearing you.
That's why the patient's ventilation didn't improve, sir?
No, that's not why. I'm getting to that, right? So the initial part of your assessment, Miss Nesbeth, was fine, but you made a critical mistake, right? So your mistake occurred in your reassessment. You didn't start from LOC, so you have not determined whether or not your patient is unresponsive or semi-responsive. You assumed that because the patient gagged, the patient is now semi-responsive. You did not check, right? And if this patient was unresponsive, the tongue is very much in the ear passage at that point. NPA would not be effective in pepping that airway patent, and that's it. That's why I kept saying to you that the ventilations are not adequate, right? Still not adequate. So the first part of the assessment was fine. It's the reassessment that went downhill, right? Once you're going to reassess your patient, start back at the level of consciousness and come down. If you are able to do that, you will not miss anything that has changed in your patient, right? Start from the beginning and come down. Yes, you did mention the oxygen, so I didn't mark you down for that, right? I marked you down for the reassessment. All right, so that's Miss Nesbeth.
No, sir.
Sorry?
Sir, this is the problem with this sort of forum sometimes, sir. Because in my head, I did start over and I saw myself, sir.
It has nothing to do with the forum. So what I'm saying to you is something I've observed with students in classroom and in this setting. It has nothing to do with the forum. The same mistake that you make here is the same mistake you will make when you're in the classroom and you have the mannequin in front of you.
What I'm saying to you, I
Nothing
started
to do with
over
the
in
forum.
my mind. I just did not verbalize that that's why I say I'm going to start over.
If it wasn't mentioned or demonstrated, then it wasn't done. I can only grade you on what I hear and what I see.
Yes, sir.
All right. So Jennings, again, did you consider the patient being in the bed, Mr. Jennings?
That's unfortunately I actually did skip over the general impression. That was my mistake.
So you have to consider where the patient is, right, and how that will affect your management of the patient. You did follow your sequence, so you follow level of consciousness. You ensure that the patient was unresponsive position, assess the airway and pulse, and you chose to go with the OA initially. And after the patient started to gag, you did your suctioning and you reassess. And in your reassessment, you did start back from the level of consciousness. And eventually you figured out that your patient was semi-conscious, but still having ventilation issues. And you chose the NPA, and you mentioned that you would synchronize with the patient's ventilation. So apart from the two things, considering the patient, you didn't consider where the patient was, and I don't recall you mentioning anything about using high flow oxygen. You can bag the patient without the oxygen attached, but once it's available, you want to get it attached and going, right? So what I've observed so far, I can definitely give you a pass, right? So I would give you a pass for that effort for the tabletop for your airway. Ms. Nesbitt, better previously than you did today. Consistency is needed, right? Going forward, you need to be consistent. Ms. Johnson, you have one more opportunity, right? So you have one more opportunity for this skill station. For 3 attempts, and then that's it, right? So you have one more opportunity. With Nesbitt and Mr. Jennings, I can grade Miss Nesbitt based on our previous performance, right? So if I'm grading you based on your previous performance, I would give you a pass. If I grade Jennings on his previous performance, I would not pass him, but I can pass him today. So both of you guys have a pass. That's good enough for me. However, remember, it is important to be consistent. You will continually see airway. It's going to be in other, definitely going to see airway in your long case trauma and your long case medical. Be prepared for it, right? So consistency is important. We can't go out there and save the patient today and mess up tomorrow. Consistency. So Ms. Johnson, one more attempt to get this tabletop airway smooth. You have one more attempt. Work on it. Yes? You hear me, Ms. Johnson?
I am you, sir. I didn't know that you were grading it, sir.
Oh, you didn't know. Well, now you do.
No.
I didn't know either too, sir.
Well, now you do. Yes? Now you do. So, would it have made a difference?
Yes, sir. I would have prepared before the class.
Okay. Okay. I see. You must be prepared at all times. At all times, you need to be prepared. So, yes, I'm evaluating you on your performance. So, one more shot at it, and we'll see where we go from here. Any questions?
Huh?
Yes, go ahead.
You just tell me what would be the next skills that we would have to pass on this one?
You guys have the skill sheets, yes?
Yes, we're gonna do all
Right.
of them.
So all of those skill sheets that is available, with the exception of the one for intubation, are skills you will be reviewing. I always go the sequence, right? So if I did airway first, upper airway first, what do you think is next, Mr. Jennings? Your signal just went down. What do you think is next?
That airway, you would do lower airway after that one.
Right. So
yeah,
lower airway is next, and that will incorporate supplemental oxygen administration. Right. So the lower airway skill sheet is that's next is going to be the one on oxygen administration, which is pretty easy because you're really just going to tell me how you would assemble the tank, whether you're using high or low flow, how you change over to another medium. That's it. Pretty straightforward. Yes, Ms. Nesbitt.
Sir, respectfully, sir, I don't think this is a fair assessment to assess our skills. I mean, 3 other persons have not completed the skills. The sessions are recorded. They are going to just simply just follow exactly. They are more guided in their approach now than we were.
Ms. Nesbitt, do you think I'm not aware of that?
But sir, I just don't get it. I don't agree with this grading thing. We weren't aware that it was being graded for first.
I'm not, Ms. Nesbitt, I'm not going to debate this. This is not something I'm going to debate. So I'm aware that the session is recorded. So it's not something that is complicated. Their scenario will not follow the same format. Right?
These 2 scenarios were pretty similar. The one that you gave on Thursday and the one that you gave today, they are similar because the steps are similar. Not even know. I think the patient was in some bed as well. And we had said
And
that.
if it is similar, why did you mess up?
I messed up because
So at the end of the day, Ms. Nesbitt, it comes down to your application of the skill. I can give everybody the same scenario 10 times. And I can guarantee you, if your understanding and the application of this is not there, you will not be successful. But I'm well aware of what I'm doing, right?
Sir, I am not questioning your ability.
Whether you agree with it or not,
But
this
sir,
is the format I am using.
Sir, you have to tell us before. I mean, you just said it a while ago, sir, that you're grading the thing. I did not go over that thing at all from Thursday. And I'm saying to you that I was distracted. It's like, sir, you wouldn't even imagine. We're at home, it's on a Saturday, there are other distractions there which sometimes we can't even control. And I'm saying to you, sir, that is probably why I messed up. But this grading thing, sir, I thought you were just practicing us so that we can get really strong with the skill and then we're graded, sir, which would be the situation under normal circumstances, sir.
Heard will make a difference. So we're going forward. We are going forward. So the next skill station that we are going to cover is the oxygen administration. Right? So make sure you're prepared for that in the next session. Make sure you're prepared. Right? Now, I can recall stating several times that you guys need to start reviewing your skill sheets. Is it that you're waiting for a set date to start reviewing the skill sheets? You're waiting until I tell you that you're going to be tested to review skill sheets at this point? Is that the case? That's a question.
No, sir. I'm not waiting on that.
Okay.
My
Is that
impression
the,
is that the skill sheets would be done in September when we come to the face-to-face with you. That was my impression, really.
yeah, but why would I tell you to download the skill sheet and start review them for we in September?
Be familiar with this.
Okay. Is that the case, Miss Johnson? Where's Miss Johnson?
I am here.
Is that the case? Are you
If what
waiting
is
until I set a date for you to focus on skills, to review the skill sheets?
no, sir.
Okay. All right. All right. Now, the other question is, if, let's say I say to you guys now that, when is the next class? Tuesday. Tuesday, you're going to get your upper airway tabletop scenario, and it will be graded. Would you be more prepared? That's a question.
I think that it would force people to be more focused on it. So I think that they would have a better performance if they do it that way. Like they would like deliberately put in the effort to learn that just because they know that that is what is going to be done.
Okay. So that's Jennings. Miss Johnson. Miss Johnson,
Yes, sir. I agree with what Mr. Jennings said, sir.
what do you agree with? Be specific. It's being recorded. So be specific. What is it that you agree with?
Sir, if we knew beforehand that we were
Mm-hmm.
going to be tested on a certain skill set, then we would put forth a lot more effort into getting it because, well, that's it, sir.
All right. Miss Nesbeth.
Sir, I agree with everything that was said so far. Just to point out to you, sir, if next week you have come and you have said to us we're going to be placing an oxygen cylinder into service, how would you do it? I would be, I would know where to start because I have not begun to even go through those skill sheets. I just glance through them and see them, but
So
I don't know what they're about.
my question then is, how is it that you people are passing the exams? If you
So,
don't know how to assemble an oxygen cylinder at this stage, how did you pass your way?
sir, I passed it. At the time, I had to study, but to actually do it and visualize it. Sir, half of the things when me study from the first part of the course, I don't remember a thing about them. Sometimes when I do ask myself a question, I have to go back to the chapters. It's not everything that we study from 2 or 3 tests ago we're going to
Miss
remember what to do, sir.
Miss Nesbeth, Airway is a practical chapter. It is a practical chapter. So that response is unacceptable. It's a practical chapter. It's not a chapter to read and pass an exam. Majority of the chapter is practical. So how is it that you're going to read it, pass the exam, and you can't remember anything going forward? If that is the case, you're gonna have problems. You're
To
going to have problems.
Sir, to assemble a cylinder, you're going to know the different parts of a cylinder because you study. So you know there's a flow meter, there's a cylinder, there's whatever else, the pins and so forth. You know it, sir. But the step by step, sir, I'm not going to remember it, and this is me. I have not started to do the skill as yet. When I do it and see how I do it, then it will be easier. That was what I said to you from the outset, sir. Some persons learn by doing stuff, and I am one of those persons. I read it and I swat it in order to get an appreciation of it to do the test. To do it, sir, in a practical setting so that it becomes a part of me is different, sir. A skill is doing practical, sir, and that is what I was telling you from the outset. I learn by seeing and doing these things.
Miss Nesbeth, are you aware of the COVID situation?
I am
Yes?
aware of the COVID
All right.
situation.
Hold on, just hold on. Are you aware from the get-go of the course how the course would be structured because of the COVID situation?
Yes, sir, and I was told that possibility exists that we might even come in next year for stuff like this, sir.
Right,
Was one
right.
coming.
So how is this an issue now?
This is an issue, sir, because I'm not getting an appreciation of some of the skills because of the medium, sir. Sir, I am aware of the situation, sir, but the persons that did the course before, they are going to be having a significant advantage over us when it comes on to skills because they were in the setting where you
Miss
showed.
Nesbeth, what you're saying is something that is outside of my control and the UE control. You need to understand that. So yes, there will be an advantage, but there is something that is called field training, right? So what you're saying is outside the control. I have no control over that. What I have control over is the modules on the platform that require skills have videos that demonstrate the step-by-step process for each skill. And I have said, review the videos, review the skill sheets. So what you're saying to me now is something that is beyond my control.
I'm not saying that it is within your purview to solve the situation, sir. What I'm saying, sir, is that if somebody is going to be, like if a surgeon is going to be operating on my body, you think that I want to be his first guinea pig because he learned the surgery by remotely looking at some video, sir? No, sir. Probably what you needs to do, and probably you can liaison with them, you and the miss, I forgot her name, is to ask them in what way they can modify the course so that we're not at a disadvantage, sir. That's all I am saying.
Nesbeth, you're clear. Miss Nesbeth, relax, relax. You know what the structure of the course is. The structure is you do the online component, we do online skill scenario review, a date is set for classroom. You come in, you do your skills in the classroom. What are you talking about? You will make adjustments. You're going to come in the classroom and do the skills that you're doing now. So what are you talking about?
What that we're being graded for now, sir?
Yes, you have to do the same skill in the classroom. I am just seeing where your understanding is now. That is the purpose of this grading process. You still have to come in the classroom. What I'm saying to you is, based on the COVID climate, it might not be September, it might be further down the line, but you will have to come in the classroom at some point and do the same skills. So you're graded in a two-step approach. So I don't understand what you're talking about.
Sir, I don't know if persons were aware that this is a two-step graded approach where we're going to be graded online for these skills and then back into the classroom. That was not my understanding. It was never communicated to me that that was going to be the situation.
You weren't aware that we were going to be doing online skills evaluation?
You said when initially, sir, initially this wasn't said to us, sir. But when it was coming down and the COVID thing was getting out of hand, you said you're going to have to teach some of the skills online, and then for some of them will come into the classroom. That was my understanding. When it comes on to performing the skills, sir, you said probably we could video, like probably you could look at how we perform some of the skills, sir. I was not aware that the grading was going to be done like
Well,
online, remotely like this. I was not
this is
aware.
what, so I am being recorded now, so make sure you understand everything that I am saying now, right? So ensure that you understand every single thing that I am saying, because I'm not gonna have this conversation again. Not gonna have this conversation again. So ensure that you understand everything I'm saying now. Going forward from this point until we finish the course, every single skill sheet that is on the platform, you will be required to talk me through the approach of that skill. If you have not reviewed the video or any video that I have uploaded for that skill, you will not be able to do it effectively. You will be graded for it, so keep that in mind. Once you have reviewed all of these skills and you have completed your exam, I mean you complete the online component of the course, the next step will be for you to come in the classroom settings when it is safe, to do so. The safety will be determined by the government, not by you, right? So it will be determined by the government, is when the government says face-to-face can take place. That was supposed to occur in September. That has changed, right? So that has changed because of the current situation. Everybody understand everything I've said so far? Just raise your hand if you understand. All right, good. So now that you have that concept in your head, right? Now that you have that concept in your head, the practical, the online practical evaluation will start next week, Tuesday. Right? So next week, Tuesday, this online practical evaluations will begin. I will be looking at upper airway and lower airway. So based on the feedback you have given, based on the feedback that you have given, the previous performances will not be used. So the previous performance will not be used, the previous grading will not be used. I will only use the grades that you get starting next week. Is that understood?
Yes, sir.
Yes,
Good.
sir.
You will only have 2 attempts. So you won't get more than 2 attempts to complete that online skill station. To complete the online skill station, you must be able to demonstrate that you understand the step-by-step approach and no critical area must be omitted. Now, each of the skill sheets that are found on the platform have critical areas that you need to follow, right? Once you omit a critical area, you will not be allowed to pass that particular skill station. Is that understood?
Yes, sir.
I understand, sir.
Good. So let's see if you have the time to prepare, if it will make a difference. right? Is that fair enough?
Yes, sir. Thank you.
Okay,
And
don't
so we
thank
will
me
see.
yet. Don't thank me yet. Do not thank me yet, right? Because you're gonna understand what I'm talking about come next week. You will understand. So that is the current situation, right? Now, as it relates to the challenges, I understand the challenges, right? I understand the challenges as it relates to the inability to not be able to do some of the skills in a classroom setting. But I know I've said this before, I'm well aware of which skills can be done through an online format and which skills can be done in person. Now, the other thing that you will be working on, so once we have completed this portion of the skills, because what I'm really doing is reviewing skills, right? That is the goal over the next couple of sessions. The next step would be for me to demonstrate some of the skills live, and then you practice the skills, right? So that's the next step after the online skill review. But if you cannot demonstrate to me that you understand the steps for the skill, we can't get to live demonstration, right? And that's the approach have used, whether it's a online course or whether it's a classroom. We always start with tabletop um, presentation. I usually, when a student is able to talk through the skill, they're gonna have problem practically doing the skill. Yes, Mr. Jennings. Go ahead.
Um, so I supposed to be
Yeah.
coming back to Jamaica on the 6th of September.
Mm-hmm.
I pray that, government don't close down the borders and then all kind of thing happen because risky flight. But once I get back to
Oh,
the campus, they are requiring us to be quarantined for this.
yes, you will have to.
I just hope that you could make some accommodation for that time period starting from the 5th of September.
The 5th of September
Until, oh God, 2 weeks after that. So I leave on the 5th. I come to Jamaica on the 6th. Then I have that 14-day period. So that's until probably the 19th or the 20th of September.
Oh, okay.
Mm.
All right. Let's see how it pencils out. At this point, there's a lot of things that are not guaranteed, right? Because we have to see what happens. The numbers are rising very, very rapidly. The government has decided to push back reopening until October. I am not sure what the university will decide as it relates to that, right? So, and the university has to basically do whatever the government tells them to do, right? They can't operate independently. So it will be based on their decision. So we'll see. And as a result of that, I will have to make adjustments. I don't want to drag out this online course, right? I don't want it to drag out. I want to wrap it up, hopefully within October or before. That was my goal. We'll see. We'll definitely see how that plays out. And as a result of that, there are some skills that you will definitely have to complete online. And what I'm thinking about is doing a live demonstration of the skill. If you do a demonstration of the skill with a family member, friend, anybody. The person videotapes, somebody videotapes that performance, and you send it via the WhatsApp group. and I can look at it and evaluate it. If I see something that don't look right, I'll send it back to you. You make assessments and send it back to me. Right? However, there are some skills that most definitely will have to be done in the classroom setting. So airway management is a must. I have to see you with the equipment in the classroom setting. Spinal immobilization on a spine board definitely is a skill that must be done in the classroom setting. So, and the supplemental oxygen administration that needs to be done in the classroom setting. I think the lung case trauma can be done outside of the classroom settings. The medical can be done. You just need a patient, really. You just need a patient, right? And the lung case trauma and medical, you're really looking at fundamentals, fundamental assessment. That's what you're looking at, right? Fundamental assessments. So going forward, I will be paying close attention to what is going on in the news and what it is that is coming out based on the information we're getting from Ministry of Health, and then discuss that with Mrs. Mackay, and we'll make some decision. But I want to wrap this course up as soon as possible. Yes, Ms. Johnson.
Yes, sir. I have a question. So
Go
you
ahead.
say you say there are certain skill set that we have to do in the classroom, like upper and lower airway. So is
Yeah.
it that if we are able to verbalize it, then when we come into the classroom, will there be a demonstration, or is it going to be
Yes.
expected that we should do it?
No, you can't do a skill that's not demonstrated. That wouldn't be practical, would it? Right? So how it works is when you come in the classroom setting, I demonstrate, you practice, I test. That's the format. I demonstrate, you practice, I test after. Yes. Go ahead, Miss Johnson.
Sir, I'm trying to get this clear because of what happened previously. So you demonstrate. So the practice is going to be the test, or we're going to get to practice and then after we do the test?
No, Miss Johnson. You practice and then I test. I didn't say test while you're practicing. Got that?
Yes, sir.
Miss. Go ahead, Miss Nestor.
On the whole assembly of the oxygen thing now, sir. You're
Yes.
going to demonstrate it, sir, and then you test? Or you're not going to do that?
I'm not hearing you.
Saying
I didn't hear that.
Like, for example, with the assembly of the cylinders and the tubings and so forth, is it that you're going to be demonstrating something to us, or we just need to follow the book and get it?
What you're talking about for next week?
Next week is the upper airway again, not the lower airway again.
Upper and lower. Upper and lower.
Right. So I'm asking you if we're supposed to just look in the book, or you assemble the cylinder and attach like a non-rebreather with the tubings and everything, or is it that you are going to be showing us exactly what to do and then we do it?
That skill, that video demonstration is in your airway module. So my response to that would be, go back to your airway, look at oxygen administration video, that's there. Everything that you see that young man doing that video is what I would expect you to verbalize. The video is there in the module. That's where you'll find it. Any question? Right, so once the video is in the module, that's the video I expect you to review for that particular skill. If it is not a part of the module or not a part of the skills that I will be looking at, then I will do a live demonstration of that particular skill. Right? And the airway video, upper airway management is there. It is in the airway module, right? It is there. Lower airway is there. So just go back and watch the videos. Right?
For the skill sheet, sir, it says airway, oxygen, and ventilation skills, upper airway adjuncts and suction. But
Right.
it's also lower airway that you should consider.
Right. So you're going to be looking at the upper airway, which is basically what you have been doing so far, right? So how the lower airway will work is I am going to give you information. As a matter of fact, we can do a dry run now if you want. You guys want to do a dry run?
Yes, sir. Yes, sir.
So hold on the Miss Nesbitt. Wouldn't that put you at an advantage over the rest?
No, this is a preliminary thing that you should do with us before you assess us. That is what I agree with you,
Okay.
sir. A preliminary dry test. If you could give us that, sir.
I'm not give you a dry test. I'm just gonna give you I'm just gonna give you an example of what I am expecting and how it will work. So I will give you a scenario. So let's use the one that you have been working on via assignment. You have a patient that is found on a location having difficulty breathing, right? The patient is responsive. The patient has a breathing rate of 30 breaths per minute. It is labored with a pulse ox reading below 90%. If you were going to administer oxygen to this patient, what supplemental device would we use, Mr. Jennings? Going once, going twice. Non-rebreather. Okay. Miss
What's the
Nesbitt,
pulse rate again, sir? I didn't get the pulse.
I didn't give you a pulse rate. I gave you a pulse ox reading below 90%. The pulse rate is not relevant to this scenario or skill. So the pulse rate is not relevant. Based on the fact that the patient is breathing at 30 breaths per minute, labored with a pulse ox below 90%, what type of supplemental device would you use?
A nasal cannula, sir.
Why are you going with a nasal?
Non-rebreather master with oxygen starting at, should I do the oxygen too?
Hold on. I'm just asking questions right now. Miss
Oh,
Johnson, what supplemental device would you use? Miss Johnson?
Sir, the person has labored breathing, difficulty breathing. So I would, well, I would assist them with breathing using a bag valve mask with an oxygen attached.
Okay. So I hear high flow with a non-rebreather. I hear high flow with non-rebreather from 2 persons, and I hear positive pressure from 1. Now, I said to you that the patient is complaining of difficulty breathing, Miss Johnson. Patient is complaining of difficulty breathing. Breathing at 30 breaths with a pulse ox below 90%. If I said to you that the patient is complaining of breathing, does it suggest that this patient is unresponsive or semi-responsive?
No, sir.
So why are we bagging the patient? All right, so I am going to give you the patient presentation, just like I did just now, and I will ask you what would be your supplemental management. And your response would be, sir, I would give this patient, I would use a non-rebreather for this patient at 10 to 15 liters per minute. I'm going to start off at 10 and probably gradually go up to 15, noting how the patient responds. Right? Then I will say to you, okay, you are going to go with high flow via non-rebreather. How would you assemble the cylinder to administer the oxygen? If it's a brand new cylinder, I'm going to make sure, I'm going to check to see that the seal is present. I'm going to remove the seal from the cylinder stem. I'm going to use the cylinder key and crack the cylinder, ensuring that nobody is in front of the port for the cylinder. Then I'm going to apply the regulator, right? Line up the pins, tighten up the regulator, turn on the oxygen cylinder, check leaks. If no leaks are present, I would attach my tubing. I would adjust the flow rate to 10 liters per minute, ensuring that the bag is fully inflated, and then I will place the mask on the patient. Now, after you tell me that, I will say to you, okay, you note that your patient's breathing pattern is starting to come down, so it's no longer breathing very fast, it's no longer that labored, the pulse ox is going up above 90%. The patient tells you that he's not able to tolerate that mask, so he's starting at about 92, the breathing rate at about 24 breaths per minute. What would you do at this point, Jennings?
You say the patient repeat what you were saying just now, sir?
Repeat what?
Repeat what you were saying in regards to the patient. You said the patient came up to about 92% and then stated that he cannot tolerate the mask no more?
Yes. The patient is
So
saying he can't tolerate that mask. What would you do at this point?
He's starting at 92. I think I would want to try and lower the flow rate. I would want to change out the mask to use a lower flow rate.
What would
See
you
if
change over to? That's what I'm asking.
So I would want to change over to, gosh, let me see, we got 10. And I wonder if I could use the next step down would be a partial rebreather. So I wonder if I should use that.
Okay, I hear you.
No, I
Hold on, Ms. Nesbeth, go ahead.
Sir, I would change now to the nasal cannula and adjust the oxygen flow between 2 to 4 liters. That's still start off low because the stats are improving. That start about 2 or 3 and then go to a maximum of 4 and see what is happening.
All right, Ms. Johnson, what would you switch over to?
Sir, I would switch over to the nasal cannula because the pulse ox rate is still low, so the patient still needs oxygen. So I would switch over to the nasal cannula and start with low. I would start at probably 3 until start with 3, sir. 3 liters per minute.
Okay. All right. So at this point, when I give you that information, you're gonna tell me, okay, sir. At this point, I'm gonna switch from high flow to a low flow device. I'm gonna go with my nasal cannula. So at this point, I'm gonna remove the mask of the patient, turn off the oxygen flow, disconnect the tubing, attach my nasal cannula, bring it up to the desired flow rate, put it on the patient. Now, once you explain all of that to me, I will tell you that, okay, if you are going to discontinue oxygen therapy, how would you do it? And then you will explain to me that, sir, first thing I'm going to do is remove the device, turn off the flow rate, disconnect the tubing, turn off the cylinder, open back the flow rate to bleed the oxygen out of the regulator until the needle go
Seriously?
back down to zero, close it back, pull the regulator off the cylinder. That's how I would disassemble. Yes, seriously, Miss Johnson.
That
Oh,
is
my
not
mic is on.
Yes, your mic was on. Your mic was on, Miss Johnson. So seriously.
sir, you have to when you have to get out the excess oxygen out of the top of the cylinder by opening the gauge, right, sir? What you
Not
saying?
the excess oxygen out of the cylinder. So when you remove the mask or the device off the patient and turn off the flow, there is oxygen trapped in the regulator, right? So there is some oxygen trapped there. So once you turn off the flow rate and turn off the oxygen tank, you have to open up the regulator, right? So open especially if you're gonna leave that regulator on the cylinder. Open it up, and that oxygen that is trapped is gonna be removed. If you don't, the next tubing that you attach to it, you're gonna be giving the patient's oxygen. That oxygen is not clean at that point. Got it? So everybody understand that? So that is what would be expected for the oxygen administration. Yes, Jennings?
Okay, so I just following up to make sure that I have the accurate understanding, right? When you start high, you say you start at 10, and the
You
patient say
don't
he
have to
cannot tolerate
you don't have to start at 10, you know, right?
10, anywhere around the range.
You can
Start
start
there.
at 10, 12, 15. It is your decision. Your patient, your decision.
So it is impractical then to move down the range. It makes sense to go to the bottom of the range and then come back up.
Right. So if I
Understand?
think that this patient cannot tolerate high flow, I'm gonna go way down and come up. Right? I'm gonna go down to low flow and see what is the lowest the patient can tolerate. Right? Because here you mentioned the I think it was partial breather that can be used, you know. Not that I'm saying it can't be used. You can use a partial rebreather. It's just that most services in Jamaica is either non-rebreather or nasal canal, right? But you have to keep in mind that a partial rebreather is actually still a high flow device. So it's not low flow, right? And we want to go down to low flow for this patient. So if you're going to a partial, it's still high flow. So if you had said, so let's say I gave you the scenario and you had said to me, it is, I would go with a I would go with a non-partial rebreather. I would allow you to assemble a partial rebreather and put it on the patient. Not able to tolerate that and see what you would do. Right? So you could follow that path down. It's just that it's going to take longer. As long as you end up, my connection just went. You still hearing me?
Yes, sir, but you know, when you was talking about the scenario, you cut out. I didn't hear what you were saying at that part. Oh,
My signal. What's going on with my? You guys hearing me now?
Yes, sir.
Sir.
yes, I hear you.
No, I'm still not. Still not hearing you guys. Still not